Guillain-Barré syndrome, GBS. Guillain-Barré syndrome, GBS, is an inflammatory disease of the PNS and is the most common cause of acute flaccid paralysis, with an annual global incidence of approximately 1-2 per 100,000 person-years. GBS occurs more frequently in males than in females, and the incidence increases with age, although all age groups can be affected. Patients with GBS typically present with weakness and sensory signs in the legs that progress to the arms and cranial muscles, although the clinical presentation of the disease is heterogeneous and several distinct clinical variants exist. Diagnosis of GBS is based on the patient history and neurological, electrophysiological, and cerebrospinal fluid (CSF) examinations. Other diseases that have a similar clinical picture to GBS must be ruled out. Electrophysiological studies provide evidence of PNS dysfunction and can distinguish between the subtypes of GBS: acute inflammatory demyelinating polyradicular neuropathy, AIDP, acute motor axonal neuropathy, AOMAN, and acute motor sensory axonal neuropathy, AMSN. Disease progression can be rapid, and most patients with GBS reach their maximum disability within 2 weeks. About 20% of patients with GBS develop respiratory failure and require mechanical ventilation. Cardiac arrhythmias and blood pressure instability can occur owing to involvement of the autonomic nervous system. This involvement of the autonomic nervous system contributes to mortality, which is estimated at 3–10% for patients with GBS, even with the best medical care available. After the initial progressive phase, patients with GBS reach a plateau phase that can last from days to weeks or months, after which they start to recover, and 60–80% of patients with GBS are able to walk independently 6 months after disease onset, with or without treatment. GBS is a monophasic illness, although some patients can deteriorate after first stabilizing or improving on therapy, a phenomenon that is referred to as a treatment-related fluctuation, TRF. Relapses of GBS can occur in 2–5% of patients. GBS is thought to be caused by an aberrant immune response to infections that results in damage to peripheral nerves, although the pathogenesis is not fully understood. In a subgroup of patients with GBS, serum antibodies are found against gangliosides, which reside at high densities in the axonema and other components of the peripheral nerves. Complement activation, infiltration of macrophages, and ochoedema are typical characteristics of affected peripheral nerves and nerve roots in patients with GBS. The incidence of GBS can increase during outbreaks of infectious illnesses that trigger the disease. Most recently, the Zika virus epidemics in French Polynesia in 2013 and in Latin America and the Caribbean in 2015–2016 were linked to an increase in individuals being diagnosed with GBS. The Zika virus outbreaks brought to light the lack of globally applicable guidelines for the diagnosis and management of GBS. Such guidelines are necessary because the diagnosis of GBS can be challenging owing to heterogeneity in clinical presentation, an extensive differential diagnosis, and the lack of highly sensitive and specific diagnostic tools or biomarkers. Guidance for the treatment and care of patients with GBS is also needed because disease progression can vary greatly between patients, which complicates an entirely prescriptive approach to management. In addition, treatment options are limited and costly, and many patients experience residual disability and complaints that can be difficult to manage. When to suspect GBS? Typical clinical features. GBS should be considered as a diagnosis in patients who have rapidly progressive bilateral weakness of the legs and/or arms, in the absence of CNS involvement or other obvious causes. Patients with the classic sensorimotor form of GBS present with distal paresthesias or sensory loss accompanied or followed by weakness that starts in the legs and progresses to the arms and cranial muscles. Reflexes are decreased or absent in most patients at presentation and in almost all patients at nadir. Dysautonomia is common and can include blood pressure or heart rate instability, pupillary dysfunction, and bowel or bladder dysfunction. Pain is frequently reported and can be muscular, radicular, or neuropathic. Disease onset is acute or subacute, and patients typically reach maximum disability within 2 weeks. In patients who reach maximum disability within 24 H of disease onset or after 4 weeks, alternative diagnoses should be considered. GBS has a monophasic clinical course, although TRFs and relapses occur in a minority of patients. Atypical clinical presentation. GBS can also present in an atypical manner. Weakness in sensory signs, though always bilateral, can be asymmetrical or predominantly proximal or distal, and can start in the legs, the arms, or simultaneously in all limbs. Furthermore, severe and diffuse pain or isolated cranial nerve dysfunction can precede the onset of weakness. Young, 6-year-old children in particular, can present with nonspecific or atypical clinical features, such as poorly localized pain, refusal to bear weight, irritability, meningism, or an unsteady gait. Failure to recognize these signs as an early presentation of GBS might cause delay in diagnosis. In a minority of patients with atypical GBS, particularly those with only motor signs, pure motor variant, and an AMN subtype on electrophysiological examination, normal or even exaggerated reflexes might be observed throughout the disease course. Variants. Some patients have a distinct and persistent clinical variant of GBS that does not progress to the classic pattern of sensory loss and weakness. These variants include weakness without sensory signs, pure motor variant, weakness limited to the cranial nerves, bilateral facial palsy with paresthesias, upper limbs, pharyngeal cervical brachial weakness, or lower limbs, paraparetic variant, and the Miller-Fisher syndrome, MFS, which in its full manifestation consists of ophthalmoplegia, auriflexia, and ataxia. In general, GBS variants are rarely pure and often overlap in part with the classic syndrome or show features that are typical of other variant forms. Besides the variants listed above, pure sensory ataxia, Bickerstaff brainstem encephalitis, BBE, and a pure sensory variant are often included in the GBS spectrum because they share clinical or pathophysiological features with GBS. However, the inclusion of these clinical variants is subject to debate as they do not fulfill the diagnostic criteria for GBS. The pure sensory variant shares clinical features with the classic sensorimotor form of GBS, with the exception of the presence of motor symptoms and signs. Pure sensory ataxia and MFS have overlapping clinical profiles, and patients with BBE usually present with symptoms resembling MFS and subsequently develop signs of brainstem dysfunction, including impaired consciousness and pyramidal tract signs. Similar to patients with MFS, individuals with sensory ataxia or BBE can exhibit IgG antibodies to GQ1b or other gangliosides in their serum. However, whether pure sensory GBS, pure sensory ataxia, and BBE are variants of GBS and/or an incomplete form of MFS is subject to debate, and careful diagnostic workup is required when these variants are suspected. Diagnostic criteria for Guillain-Barré syndrome, features required for diagnosis: progressive bilateral weakness of arms and legs. Initially, only legs may be involved. Absent or decreased tendon reflexes in affected limbs. At some point in clinical course, features that strongly support diagnosis. Progressive phase lasts from days to 4 weeks, usually 2 weeks. Relative symmetry of symptoms and signs. Relatively mild sensory symptoms and signs, absent in pure motor variant. Cranial nerve involvement, especially bilateral facial palsy. Autonomic dysfunction, muscular or radicular back or limb pain. Increased protein level in cerebrospinal fluid, CSF. Normal protein levels do not rule out the diagnosis. Electrodiagnostic features of motor or sensorimotor neuropathy. Normal electrophysiology in the early stages does not rule out the diagnosis. Features that cast doubt on diagnosis. Increased numbers of mononuclear or polymorphonuclear cells in CSF, 50x106L. Marked persistent asymmetry of weakness. Bladder or bowel dysfunction at onset or persistent during disease course. Severe respiratory dysfunction with limited limb weakness at onset. Sensory signs with limited weakness at onset. Fever at onset, nadir 24H. Sharp sensory level indicating spinal cord injury. Hyperreflexia or clonus. Extensor plantar responses. Abdominal pain. Slow progression with limited weakness without respiratory involvement. Continued progression for 4 weeks after start of symptoms. alteration of consciousness, except in Bickerstaff brainstem encephalitis. How to diagnose GBS. A. Laboratory investigations. Laboratory testing is guided by the differential diagnosis in individual patients. But in general, all patients with suspected GBS will have complete blood counts and blood tests for glucose, electrolytes, kidney function, and liver enzymes. Results of these tests can be used to exclude other causes of acute flaccid paralysis, such as infections or metabolic or electrolyte dysfunctions. Further specific tests may be carried out with the aim of excluding other diseases that can mimic GBS. Testing for preceding infections does not usually contribute to the diagnosis of GBS, but can provide important epidemiological information during outbreaks of infectious diseases, as was seen in previous outbreaks of Zika virus and C. jejuni infection. The diagnostic value of measuring serum levels of antiganglioside antibodies is limited and assay-dependent. A positive test result can be helpful, especially when the diagnosis is in doubt, but a negative test result does not rule out GBS. Anti-GQ1B antibodies are found in up to 90% of patients with MFS and therefore have greater diagnostic value in patients with suspected MFS than in patients with classic GBS or other variants. When GBS is suspected, we advise not to wait for antibody test results before starting treatment. B. Cerebrospinal fluid examination. CSF examination is mainly used to rule out causes of weakness other than GBS and should be performed during the initial evaluation of the patient. The classic finding in GBS is the combination of an elevated CSF protein level and a normal CSF cell count, known as albuminocytological dissociation. However, protein levels are normal in 30–50% of patients in the first week after disease onset and 10–30% of patients in the second week. Therefore, normal CSF protein levels do not rule out a diagnosis of GBS. Marked pleocytosis, was 50 cells, mmL, suggests other pathologies, such as leptomeningeal malignancy or infectious or inflammatory diseases of the spinal cord or nerve roots. Mild pleocytosis, 10–50 cells ml, though compatible with GBS, should still prompt clinicians to consider alternative diagnoses, such as infectious causes of polyradiculitis. C. Electrodiagnostic studies. Electrodiagnostic studies are not required to diagnose GBS. However, we recommend that these studies are performed wherever possible, as they are helpful in supporting the diagnosis, particularly in patients with an atypical presentation. In general, electrophysiological examination in patients with GBS will reveal a sensorimotor polyradiculoneuropathy or polyneuropathy indicated by reduced conduction velocities, reduced sensory and motor evoked amplitudes, abnormal temporal dispersion, and/or partial motor conduction blocks. Typical for GBS is a sural sparing pattern in which the sural sensory nerve action potential is normal, while the median and ulnar sensory nerve action potentials are abnormal or even absent. However, electrophysiological measurements might be normal when performed early in the disease course, within 1 week of symptom onset, or in patients with initially proximal weakness, mild disease, slow progression, or clinical variants. In these patients, a repeat electrodiagnostic study 2–3 weeks later can be helpful. In patients with MFS, results of electrodiagnostic studies are usually normal or demonstrate only a reduced amplitude of sensory nerve action potentials. Electrodiagnostic studies can also differentiate between the 3 electrophysiological subtypes of classical GBS: AIDP, AMAN, and AMSAN. Several sets of electrodiagnostic criteria exist that aim to classify patients into these different electrophysiological subtypes on the basis of the presence of specific electrodiagnostic characteristics in at least 2 motor nerves. International consensus is yet to be reached on which set of criteria best defines the electrophysiological subtypes. However, about 1/3 of patients with GBS do not meet any of these criteria and are labeled equivocal or inexcitable. Studies have demonstrated that repeating electrodiagnostic studies 3–8 weeks after disease onset might aid electrodiagnostic classification by allowing classification of cases that were initially unclassifiable, or reclassification of cases that were initially classified as AIDP, AMAN, or AMSAN, although this practice is controversial. D-imaging. MRI is not part of the routine diagnostic evaluation of GBS, but can be helpful, particularly for excluding differential diagnoses such as brainstem infection, stroke, spinal cord or anterior horn cell inflammation, nerve root compression, or leptomeningeal malignancy. The presence of nerve root enhancement on gadolinium-enhanced MRI is a nonspecific but sensitive feature of GBS and can support a GBS diagnosis, especially in young children, in whom both clinical and electrophysiological assessment can be challenging. In light of recent outbreaks of acute flaccid myelitis in young children, the clinical presentation of which can mimic GBS, the potential use of MRI to distinguish between these two diagnoses should be given special attention. However, clinicians should be mindful that nerve root enhancement can be found in a minority of individuals with acute flaccid myelitis. A new potential diagnostic tool in GBS is ultrasound imaging of the peripheral nerves, which has revealed enlarged cervical nerve roots early in the disease course, indicating the importance of spinal root inflammation as an early pathological mechanism. This technique might therefore help establish a diagnosis of GBS early in the disease course, although further validation is required. When to admit to the ICU. Reasons to admit patients to the intensive care unit, ICU, include the following: evolving respiratory distress with imminent respiratory insufficiency, severe autonomic cardiovascular dysfunction, for example, arrhythmias or marked variation in blood pressure, severe swallowing dysfunction or diminished cough reflex, and rapid progression of weakness. A state of imminent respiratory insufficiency is defined as clinical signs of respiratory distress, including breathlessness at rest or during talking, inability to count to 15 in a single breath, use of accessory respiratory muscles, increased respiratory or heart rate, vital capacity, 15-20 milliliters per kilogram, or 1L, or abnormal arterial blood gas or pulse oximetry measurements. As up to 22% of patients with GBS require mechanical ventilation within the first week of admission, patients at risk of respiratory failure must be identified as early as possible. The Erasmus GBS Respiratory Insufficiency Score, EGR, as prognostic tool was developed for this purpose and calculates the probability, 190%, that a patient will require ventilation within 1 week of assessment. Risk factors for prolonged mechanical ventilation include the inability to lift the arms from the bed at 1 week after intubation, and an axonal subtype or unexcitable nerves in electrophysiological studies, 75. Early tracheostomy should be considered in patients who have these risk factors. When to start treatment. Immunomodulatory therapy should be started if patients are unable to walk independently for 10M. Evidence on treatment efficacy in patients who can still walk independently is limited, but treatment should be considered, especially if these patients display rapidly progressive weakness or other severe symptoms, such as autonomic dysfunction, bulbar failure, or respiratory insufficiency. Clinical trials have demonstrated a treatment effect for intravenous immunoglobulin, IVIG, when started within 2 weeks of the onset of weakness, and for plasma exchange when started within 4 weeks. Beyond these time periods, evidence on efficacy is lacking. Treatment options, treatment strategies, IVG, 0.4 g per kilogram body weight daily for 5 days, and plasma exchange, 250 milliliters, plasma kg body weight in 5 sessions, are equally effective treatments for GBS. IVIG and plasma exchange carry comparable risks of adverse events, although early studies showed that plasma exchange was more likely than IVIG to be discontinued. As IVIG is also easier to administer and generally more widely available than plasma exchange, it is usually the treatment of choice. Besides IVIG and plasma exchange, no other procedures or drugs have been proven effective in the treatment of GBS. Although corticosteroids would be expected to be beneficial in reducing inflammation and therefore disease progression in GBS, 8 randomized controlled trials on the efficacy of corticosteroids for GBS showed no significant benefit, and treatment with oral corticosteroids was even shown to have a negative effect on outcome. Furthermore, plasma exchange followed by IVIG is no more effective than either treatment alone, and insufficient evidence is available for the efficacy of add-on treatment with intravenous methylprednisolone in IVIG-treated patients. In clinical settings where resources are limited, small volume plasma exchange might be an economical and relatively safe alternative to conventional plasma exchange. But this approach cannot be recommended for general use until its efficacy has been established in further trials. Antimicrobial or antiviral treatment can be considered in patients with GBS who have an ongoing infection. However, preceding infections have usually resolved before the onset of weakness. Specific patient groups, GBS variants. Patients with pure MFS tend to have a relatively mild disease course, and most recover completely without treatment within 6 months. Therefore, treatment is generally not recommended in this patient group, but patients should be monitored closely because a subgroup can develop limb weakness, bulbar, or facial palsy, or respiratory failure. The severity of the disease course of BBE justifies treatment with IVIG or plasma exchange, although evidence for the efficacy of treatment in this context is limited. For the other clinical variants, no evidence regarding treatment is currently available, although many experts will administer IVIG or plasma exchange. Pregnant women. Neither IVIG nor plasma exchange is contraindicated during pregnancy. However, as plasma exchange requires additional considerations and monitoring, IVIG might be preferred. Children. There is no indication that it is necessary to deviate from standard adult practice when treating children with GBS. Evidence on the relative efficacies of plasma exchange and IVIG in children is limited. However, as plasma exchange is only available in centers that are experienced with its use and seems to produce greater discomfort and higher rates of complications than IVIG in children, IVIG is usually the first-line therapy for children with GBS. Although some pediatric centers administer IVIG as 2 g per kilogram body weight over 2 days, rather than the standard adult regimen of 2 g per kilogram body weight over 5 days. One study indicated that TRFs were more frequent with a 2-day regimen, 5 of 23 children, than with the 5-day regimen, 0 of 23 children. Monitoring disease progression. Regular assessment is required to monitor disease progression in the occurrence of complications. First, routine measurement of respiratory function is advised, as not all patients with respiratory insufficiency will have clinical signs of dyspnea. These respiratory measurements can include usage of accessory respiratory muscles, counting during expiration of 1 full capacity inspiratory breath. A single breath count of 119 predicts a requirement for mechanical ventilation, vital capacity, and maximum inspiratory and expiratory pressure. Clinicians should consider using the 20-30-40 rule, whereby the patient is deemed at risk of respiratory failure if the vital capacity is 20 milliliters per kilogram, the maximum inspiratory pressure is 30 cmOH2O, or the maximum expiratory pressure is 40 cmOH2O. Second, muscle strength in the neck, arms, and legs should be assessed using the Medical Research Council grading scale or a similar scale, and functional disability should be assessed on the GBS Disability Scale, a widely used tool for documenting GBS disease course. Third, patients should be monitored for swallowing and coughing difficulties. Last, autonomic dysfunction should be assessed via electrocardiography and monitoring of heart rate, blood pressure, and bowel and bladder function. The nature and frequency of monitoring depends on the rate of deterioration, the presence or absence of autonomic dysfunction, the phase of the disease, and the healthcare setting, and should be carefully assessed in each individual patient. Up to 2/3 of the deaths of patients with GBS occur during the recovery phase and are mostly caused by cardiovascular and respiratory dysfunction. We therefore advise clinicians to stay alert during this phase and monitor the patient for potential arrhythmias, blood pressure shifts, or respiratory distress caused by mucus plugs. This monitoring is especially important in patients who have recently left the ICU and in those with cardiovascular risk factors. Managing early complications. Complications in GBS can cause severe morbidity and death. Some of these complications, including pressure ulcers, hospital-acquired infections, for example, pneumonia or urinary tract infections, and deep vein thrombosis, can occur in any hospitalized bedbound patient, and standard practice preventive measures and treatment are recommended. Other complications are more specific to GBS, for example, the inability to swallow safely in patients with bulbar palsy, corneal ulceration in patients with facial palsy, and limb contractures, ossification and pressure palsies in patients with limb weakness. Pain, hallucinations, anxiety, and depression are also frequent in patients with GBS, and caregivers should specifically ask patients whether they are experiencing these symptoms, especially if patients have limited communication abilities and/or are in the ICU. Recognition and adequate treatment of psychological symptoms and pain at an early stage is important because these symptoms can have a major impact on the well-being of patients. Caregivers should also be aware that patients with GBS, even those with complete paralysis, usually have intact consciousness, vision, and hearing. It is important, therefore, to be mindful of what is said at the bedside and to explain the nature of procedures to patients to reduce anxiety. Adequate management of complications is best undertaken by a multidisciplinary team, which might include nurses, physiotherapists, rehabilitation specialists, occupational therapists, speech therapists, and dietitians. Managing clinical progression, insufficient response to treatment. About 40% of patients treated with standard doses of plasma exchange or IVIG do not improve in the first 4 weeks following treatment. Such disease progression does not imply that the treatment is ineffective, as progression might have been worse without therapy 6. Clinicians may consider repeating the treatment or changing to an alternative treatment, but at present, no evidence exists that this approach will improve the outcome. A clinical trial investigating the effect of administering a second IVIG dose is ongoing. Treatment-related fluctuations. TRFs are observed in 6–10% of patients with GBS and are defined as disease progression occurring within 2 months following an initial treatment-induced clinical improvement or stabilization. TRFs should be distinguished from clinical progression without any initial response to treatment. The general view is that a TRF indicates that the treatment effect has worn off while the inflammatory phase of the disease is still ongoing. Therefore, patients with GBS who display TRFs might benefit from further treatment, and repeating the full course of IVIG or plasma exchange in these patients is a common practice, although evidence to support this approach is lacking. CIDP. In tilde, 5% of patients with GBS, repeated clinical relapses, suggest a more chronic disease process, and the diagnosis is changed to acute-onset CIDP. Acute-onset CIDP typically presents with 3 or more TRFs and/or clinical deterioration 8 weeks after disease onset. Predicting outcome. Most patients with GBS, even those who were tetraplegic at nadir or required mechanical ventilation for a long period of time, show extensive recovery, especially in the first year after disease onset. About 80% of patients with GBS regain the ability to walk independently at 6 months after disease onset. The probability of regaining walking ability can be calculated in individual patients using the modified Erasmus GBS outcome score, MAGO's prognostic tool. Despite the generally positive prospects for patients with GBS, death occurs in 3–10% of cases, most commonly owing to cardiovascular and respiratory complications, which can occur in both the acute and the recovery phase. Risk factors for mortality include advanced age and severe disease at onset. Long-term residual complaints are also common and can include neuropathic pain, weakness, and fatigue. However, recovery from these complaints may still occur 5 years after disease onset. Recurrent episodes of GBS are rare, affecting 2–5% of patients, but this percentage is still higher than the lifetime risk of GBS in the general population, 0.1%. Many vaccines carry a warning about GBS, although prior GBS is not a strict contraindication for vaccination. Discussion with experts might be useful for patients who were diagnosed with GBS 1 year before a planned vaccination or who previously developed GBS shortly after receiving the same vaccination. In these patients, the benefits of vaccination for specific illnesses, for example, influenza in elderly individuals, must be weighed against the small and possibly only theoretical risk of a recurrent GBS episode 14. Planning rehabilitation. Patients with GBS can experience a range of long-term residual problems, including incomplete recovery of motor and sensory function, as well as fatigue, pain, and psychological distress. Before the patient is discharged, These possible long-term effects of GBS should be considered and managed. Physical function. Arranging a rehabilitation program with a rehabilitation specialist, physiotherapist, and occupational therapist is a crucial step towards recovery. Programs should aim to reduce disability in the early stages of recovery and later to restore motor and sensory function and physical condition to pre-disease levels. Exercise programs for patients with GBS, which include range of motion exercises, stationary cycling, and walking and strength training, have been shown to improve physical fitness, walking ability, and independence in activities of daily living. However, the intensity of exercise must be closely monitored as overwork can cause fatigue. Fatigue, unrelated to residual motor deficits, is found in 60–80% of patients with GBS and is often one of the most disabling complaints. Other causes should be considered before concluding that fatigue in a patient is a residual result of GBS. As with recovery of physical function, a graded supervised exercise program has been shown to be useful in reducing fatigue. Pain. Severe pain is reported in at least 1/3 of patients with GBS 1 year after disease onset and can persist for 10 years. Chronic pain in GBS is characterized by muscle pain in the lower back and limbs, painful paresthesias, arthralgia, and radicular pain. Although the pathogenesis of this pain is not fully understood, muscle pain and arthralgia might be attributable to immobility, and neuropathic pain might be caused by regeneration of or persistent damage to small nerve fibers. Management strategies include encouraging mobilization and administering drugs for neuropathic or nociceptive pain. Psychological distress. Rapid loss of physical function, often in previously healthy individuals, can be severely traumatic and may cause anxiety and/or depression. Early recognition and management of psychological distress is important in patients with GBS, especially as mental status can influence physical recovery and vice versa. Referral to a psychologist or psychiatrist might be beneficial for some patient. Providing accurate information to patients on the relatively good chance of recovery and low recurrence risk, 2–5%, can help reduce their fear. Connecting patients with others who have had GBS can also help guide them through the rehabilitation process. The GBS CIDP Foundation International, the International Patient Association for GBS, and other national organizations can help establish these networks. Take-home message. Classic Guillain-Barré syndrome, GBS, is an acute-onset ascending sensorimotor neuropathy, but the disease can present atypically or as a clinical variant. Abnormal results in electrophysiological studies and a combination of an increased protein level and normal cell count in cerebrospinal fluid are classic features of GBS. But patients with GBS can have normal results in both tests, especially early in the disease course. Respiratory function should be monitored in all patients, as respiratory failure can occur without symptoms of dyspnea. Intravenous immunoglobulin and plasma exchange are equally effective in treating GBS. No other treatments have been proven to be effective. The efficacy of repeat treatment in patients who have shown insufficient clinical response is uncertain. Nevertheless, this practice is common in patients who show deterioration after an initial treatment response. Clinical improvement is usually most extensive in the first year after disease onset and can continue for 5 years.